Good morning, Academy, and thank you for the opportunity to presenting today our work over the last year and past 10 years, in fact, in building safe airway programs in low resource settings. And if there's ever been a project that has spanned the country and the world, and the premise of the combined otolaryngologic academies across the world, we really think this is it. And we were excited to come and talk to you in person, but welcome to the COVID era and the pandemic. So we are coming to you from countries all over the world by way of Zoom, and we hope that this works, and we are going to move forward together. My name is Chris Hartnick. I'm a professor at the Department of Otolaryngology at the Harvard Medical School, and along with my former fellow who put his title now, Sita Jayawardena, who put his title as the fellow, who is now going to start his own airway program and take over the world in Minnesota, and is starting out on Monday on his own program. But he has been intimately involved with Operation Airway and been to the Dominican Republic and to El Salvador. And along with Evelyn Zabla, who is our program director for Operation Airway, as well as the program director for the Benjamin Harry Pakin, and as well as the heart and soul of all of our missions together. And with the great good fortune to all of us to have worked with Dr. Marcos Mirambeau, who's the director of the Pediatric Otolaryngology and the Pediatric Airway Center at the Robert Reed Cabral Hospital in the Dominican Republic. And I must say is one of the finest teachers of residents and students that I've ever seen, and the Dominican Republic and his students are lucky to have him. And Dr. Jose Bonilla, who's the division director of Pediatric Otolaryngology at the Bloom Hospital in El Salvador, who kindly and patiently has taught his junior faculty how to share the airway burden with him, and cares for every child as if that child were his own. Together we have grown and we have learned, and it's our experiences together that we would like to share with you over this past hour. Operation Airway, as it were, began in 2007 when I was still doing cleft lip and cleft palate surgery as part of our mission work, where these forms of missions where cleft palates are surgeries you can do. They are relatively straightforward. You can leave, and you need very little teamwork collaboratively across the countries to make these situations work. And while I was there, the old head of the Pediatric Intensive Care Unit at Mass General, Dr. Natan Novisky, featured in the top right, was teaching a pediatric critical care course in Quito, in the same country, but just in a different city, where he saw a young boy who had undergone an ophthalmologic procedure about a month or two before, but who was immensely stridorous and who could not breathe. And he knew enough to know that we needed the same kind of teamwork there in Ecuador than we did back in Boston. And he called me, not by WhatsApp, not by any of the formal technology, by old-fashioned phones, which we had in that scenario. And I went up to Quito to help Natan. And this child had a posterior glottic stenosis, and we placed a tracheostomy. And after we placed a tracheostomy, we realized that we had to work with the surgeons and the intensivists and the pediatricians and the respiratory therapists and the nurses, all to know how to take care of these children together. That these children are truly an integrated practice unit that we all have to learn to work with together as a team in order to care for these children. And we asked ourselves, did this exist in Ecuador? And we started by building that form of model. Again, as many of you in the Academy know, this form of stenosis in its simplest form is taken care of by airway reconstruction or rib grafting. But we have 5 years to teach our residents and then 2 years to teach our fellows. How do you rib graft? How do you do airway reconstruction? What are the complications of this? And how do we transpose this knowledge to 1 week increments, 2 week increments, and move forward as we work together to learn to build these programs across the world. Here's Eric 2 years later, after a team has been built and after his operation. But there's so many stories of this. And perhaps Jose will touch about this young story, or perhaps Evelyn will when she talks about why El Salvador. But there are stories of these children needing airway reconstruction all over the world. And what I would say is, when to get those children from the time when they have their trachs to the time when they can eat and breathe and swallow and do all of these functions together takes a team. And since 2007, we have worked for 4 to 5 years in Ecuador, to the point they have their own airway program now, and they're doing their own cases and teaching their own care in that situation. We've worked with the Dominican Republic, and Dr. Mirambeau will talk about his experience. We've worked in El Salvador, and Dr. Bonilla will talk about his experience. And our next missions are in Colombia and Peru. And at the end, as we'll talk about, one of the goals of this is not just to have Boston to the Dominican Republic or Boston to El Salvador, but now that Dr. Mirambeau and Dr. Bonilla have learned their techniques and taught this, we welcome them to come with us to Colombia and Peru, and the world expands in this fashion as we learn together. So with that in mind, as a framework, we're going to start with the El Salvador experience. And Evelyn, who is when we say she is the program director, but there is no part of Operation Airway in any country in the world that Evelyn does not touch and that does not help. And it does not help us understand not just the missions, but the cultures, what people want, how we can work together. So I thought we would ask Evelyn to say, if we're going to work together and we're going to choose a country with which to start working and a team to which, why El Salvador? Why the Bloom Hospital? Where were they before they came? What were they doing? And what do you think they wanted to learn, and how could we work together? Evelyn?
Thank you. So I think to start on the first question on why El Salvador, I think it's been very important that each country that we've been to has wanted Operation Airway to come down, and we have created that relationship from the beginning on, like, they want this program, they want to learn, and they're eager to work with us to help the kids most in need. So El Salvador became the perfect hosting country. They had a need. The surgery before we came wasn't being done, so a lot of these children would get a trach, and then there was nothing that their team could do to transition them from having a trach to being able to eat and live without a trach once their lesion was healed. So we began the talk, and the Bloom Hospital was the perfect hospital in El Salvador, because it's the reference hospital for the reference children hospital for the country. And for some other countries in Latin America, for instance, there are a lot of children from Guatemala or Honduras that come to the Bloom Hospital to get care because of their resources and expertise. So that's why we chose the Benjamin Bloom Hospital, and because of the relationship that began to create with that team. As I said, before we came in, we saw the eagerness from the whole department, the ENT department, anesthesiology, pediatricians. There was an eager to learn how to take care of these kids beyond having a trach. So they wanted to learn, and so far, I think what they've wanted was what we have created, a partnership where we can take care of these kids together until they can develop their own programs and then take care of their kids on their own, without Operation Airway being a part of the need in the moment.
Yeah, I think that's wonderful, and I think that's exactly why we started. And Jose, in your own words, we'd love to get some sense of how did your team look like before, and how did your practice look like before, and why did you even want to start working with us in terms of team building and when you did, how many years did you think this all would take? And how has your experience been like? And you can speak in English or in Spanish, but if you speak in Spanish, go slowly for Evelyn to translate, and we'll go back and forth and make it work like that.
Bien, lo haré en español para darle un poquito de trabajo a Evelyn.
Evelyn, you're on mute. Somehow that doesn't come through. Yeah.
So Dr. Bonilla just said that he would do the presentation in Spanish so I can have more work.
Ha sido una experiencia increíble. Antes de que se iniciara el programa con el Dr. Harnick y su grupo, las expectativas de nuestros niños eran muy pocas.
It has been a great experience. Before we started this program with Dr. Harnick and his team, the expectation of our children with trach was very little. They had no expectations.
Go ahead, Jose, and in terms of maybe you could say something about how many years did you think this would take in terms of learning to pull the teams together, and what issues did you face within your own hospital with bringing the team together? Evelyn, maybe you could translate that.
Doctor Bonilla, que cuál ha sido su experiencia. Dice doctor que cuántos años usted pensó con su equipo que esto iba a tomar, cómo se veía esto antes, cuál es su opinión sobre eso.
En mi opinión, esto no tenía un futuro antes de conocer el grupo del Dr. Harnick y a ti, Evelyn, porque nuestros niños tenían su cánula de traqueostomía y con eso se iban de nuestro hospital. No se les hacía más que dilatación glótica o subglótica, pero no teníamos un programa establecido de traqueoplastías hasta que el Dr. Harnick aparece en escena.
So Dr. Bonilla wants to say that before this, there wasn't much hope for the kids, and there wasn't much care that they could give, that a child would leave the hospital bloom with their trach, and then there was nothing else that they could offer. They did offer some balloon dilations, but there wasn't any hope until Operation Airway team came down to help these kids and see the development of the program.
Maybe, Marcos, maybe it's a good place to ask you in terms of, with the context of building an Airway program and working with Operation Airway, and then how did your hospital want such a program? And in terms of the relationship with the intensive care unit and the anesthesiologists and caring for these children together, how did that come about that you were able to achieve that?
First of all, I want to say thank you for inviting me to this conference. And second, and I'm very proud to be part of this program, because right now we can give some hope and solution to our patients with airway problems. I heard about this program the first time from a colleague, Dr. Ramon Franco. He's a laryngologist from Harvard School, a colleague from Dr. Harnick. And we talk about the problem in Dominican Republic and how can we fix this problem. And this is the first time that I heard about the program of Operation Airway. The second question is, I want to achieve a strong and safe program in Dominican Republic and teach the resident how to treat those patients. And I feel that we achieve 75% of my goal right now. And for the last two questions, I have one answer. And this answer is, I think that we can treat patients from Haiti and made this program bigger and help this poor country uh, with some air problem in Haiti. I think that this is my goal because we share the same island, and I think that they need some help too. My goal is to complete the 100% of this program. This program helped a lot of patients in Dominican Republic. Right now, my resident know how to treat this patient, how to take care. I also teach the ICU resident, and also I can share some knowledge with the ICU attendant in order to get better result for our patients.
I think that's a wonderful answer, Marcos, and true. And I think for those members of the Academy and the world listening here, the first thing and criteria that we looked for with partnerships are physician champions like Dr. Mirambeau and Dr. Bonilla, who are marvelous surgeons, but also marvelous teachers who want to work with their own anesthesiologists and own intensivists to build their own programs, knowing that surgery is just half the battle, that we can do the best surgery in the world, but if we don't have a team and we don't care for those patients in the operating room, in the intensive care unit, and then if we don't pass the education along to our residents and to the next generation, we're never going to be successful. So the local champions is so important.
I think that
Jose, did you, Dr. Bonilla and Evelyn, maybe you can translate, did you find culturally it was hard to get the intensive care unit and the anesthesiologists to work together in such a way?
Doctor Bonilla, dicen que si usted encontró alguna dificultad cultural al momento de involucrar al departamento de unidad de cuidados intensivos y al departamento de anestesiología en este tipo de programas, si encontró algún problema.
No he encontrado ningún problema. Todos han estado anuentes a aceptar una nueva forma de trabajo, la cual ha sido protagonizada por el doctor Harnick y su grupo.
He hasn't found any problem with any of the teams in his hospital. He said that he found them very willing to accept this new program that Operation Airway was bringing and to take care of these kids.
And Mark?
Es más, ya estamos trabajando en una forma más coordinada. Los pacientes con problemas de vía aérea los estamos manejando en conjunto con la gente de cuidados intensivos, los pediatras y los anestesiólogos.
He said that furthermore, there's been a change that now they're taking care of the kids in the ICU or in conjunction with the pediatricians together to help them kids that have airway difficulties to help them since from the beginning.
Marcos, what has your experience been like?
Well, at the beginning, it was a hard time with the ICU doctors and nurse, and also the pediatric residents, because they didn't know how to take care of those patients. But right now, we teach them how to treat them, and they start to work, to feel comfortable to work with those patients. And I think that we create with Operation Wait not only a way of treat these patients, we create a friendship and also recreate a new way of work, because we made a huge team. We make a team with the ICU doctor, with the nurse, and with the pediatric general residents, because it's not a one person work, it's a teamwork. I think so.
Yeah, I think that's just wonderful. And I think so when we go down, we bring our myself as a pediatric ENTs, pediatric anesthesiologists, pediatric intensive care unit doctors, pediatric speech pathologists, and pediatric nursing. And we link one-to-one, service to service, to try to show how we work together in these teams. And both, again, both in El Salvador and the Dominican Republic, with the championship of Dr. Bonilla and Dr. Mirambo, it would not be possible without this. And the product of this has really been international papers also describing this, that we are co-authoring together as a group to expand our experience. And maybe that's a good way to start with. One of the things when we do airway surgery, we know we have to be safe. So we start off together in each time showing, almost doing simulations together. What would we do if things went wrong? What techniques would we have to work together? And we start with basic measures, even before we start with the airway surgery. So Asita, maybe you could walk us through needle cricothyroidotomy and the tube within a tube, and why we would use these for the younger and the older tubes in preparing even to do the bronchoscopies on these children, maybe before they have trachs or after. Oh, are your slides there?
There you go. I think they might be after this.
Yeah, let's go.
There you go. Perfect. So I would just say, regarding when it comes to surgical teaching, especially going into places like the Dominican and El Salvador, I think it's critically important to use tools that are recreatable. And so for us to come and bring a fancy storage scope or something like that, but then bring it back to Boston isn't actually helpful in terms of teaching. So one of the things that we have tried to do is use kind of surgical safe tools that can be made with really basic instruments. So the needle crite kit, which we assemble, and I assemble this, in Boston, I'll assemble it in my own practice in Minneapolis, but we use these tools before we start any complicated bronch, which may need a needle crite readily available. We assemble one of these, and all that it is, you can see in the picture, a 3 cc syringe connected to a 14 gauge angiocatheter, which is then placed into the airway with a saline flush drawing back to ensure that you're in the airway, which is identified by having bubbles within the saline catheter, then passing the 14 gauge catheter through into the airway and connecting it with that 3 cc syringe, which then connects to a 7.0 endotracheal tube and therefore the anesthesia circuit. So we do that, for complicated patients that we think we, may need that to be readily available at the bedside. And that's something that is helpful to have around and can be assembled using basic tools that are, ubiquitous in any operating room. I'd say similarly that the tube within a tube, which you can also see pictured here, is a 5.0 endotracheal tube sewn to a 3.0 endotracheal tube. Again, not a complicated to make, but it's actually very important for older patients who have a narrow either subglottic stenosis or distal tracheal stenosis, where passing a 3.0 endotracheal tube may be too short because the child is 15 years old, in which case you would need the length of the 5.0 endotracheal tube, but the actual diameter of the 3.0 endotracheal tube. And so combining those things by sewing them together is something that we teach everybody, before doing our airway surgeries. I think it's important to know.
So these are two techniques, and I just would say that the other, as I'm going to go back and forth, the other ways of knowing how to be safe, especially as we start learning these surgeries together. And when I say this, one of the things that I've been so impressed with Dr. Bonilla and Dr. Mirambo, they know how to do these surgeries. The reason Marcos would say, and I remember this, I know how to do these surgeries well. I want to know how to do them better. And I want to know how to do them, choose between surgeries. And he really has become a master. But to know how to do this, as all of us who do this, is not necessary to know one surgery, it's to know multiple surgeries and how to be safe. And this is just an example of a single stage reconstruction, and where we know where the child will be nasally intubated, and the green and the red are the airway stents. The top is what is a double stage reconstruction, where the purple is the stent above the tracheotomy tube and through the vocal cords. And these really, prior to Operation Airway and starting to work together around the world, were the two mainstay surgeries that were done. Working together with Dr. Mirambeau and Dr. Bonilla, we realized that many of these children needed to be both safe. We needed stents to make these grafts come forward. But in many of these children, one of the issues were, as Marcos mentioned, the ICU and the pediatricians weren't comfortable in the beginning. And what happens if the stent moves or the endotracheal tube plugs? How do we keep these children safe while this happens, and while Dr. Bonilla and Dr. Mirambeau educate their team and work with their intensivists? And this was the genesis of the 1.5 stage LTR, where we used an endotracheal tube and a small trach at the same time through the stoma, such that if that endotracheal tube plugged, or if there was an accidental extubation, or if the child was not sedated enough, there would be a second airway so the child would not die. And this technique has been so helpful for us in both the Dominican Republic as well as El Salvador. Both Marcos and Jose are now, they can now do any of those techniques, but we've brought these techniques now back to Boston and back to Minneapolis, because we realize that children in Minneapolis and Boston, they need to be safe too. And one of the things when we spend time working all around the world saying, how do we teach each other, not just teach one to vertically from one way to the other, and how do we keep these children safe, is some of these techniques span the world. And other techniques we've learned to do step back even further than this in terms of, and they stay to something on the order of what do we do with regards to teaching so that these children who have trachs or endotracheal tubes, so that they don't plug? How do we teach this kind of care together here and around the world? And how do we learn to teach our ICUs how to keep those endotracheal tubes in place while these kids are in the intensive care unit? And Asita, maybe you want to touch upon this.
Yeah, of course. So I'll start with this slide that is pictured on the screen. And again, it kind of goes back to using sustainable resources. So portable suction machines in the United States, as you know, can be hard to come by, even in high resource settings. And so what we found is actually that using non-electric kind of pump handle suctions that create a vacuum just by pumping it can actually be useful, especially in kind of the immediate post-operative period, in order to ensure that the surgical airway remains patent by connecting it to these suction catheters. So this is a tool that's been very useful for us kind of in the immediate kind of perioperative setting. Another thing that we've done, which also kind of utilizes the resources that are readily available, is we have created video modules, but instead of just having them be accessible on the internet, we've created QR codes, and we hang these QR codes on the side of each patient's bedside. And they're not only for, surgeons to learn surgical techniques, they're also for nurses to understand kind of the perioperative care for these patients, and also for parents to understand, for example, how to adjust your infant's trach ties, how to change your infant's trach. So these kinds of things, anybody who has a cell phone can just look that up on their phone, and then they have the link to the video. So parents have access to these sort of educational materials kind of at all times. Another thing that we
I would just stop
or-
for 1 second,
Yeah.
just to say here that that suction machine was the idea of a team from South Africa who were giving us this. So the world is small, and we bring from one country to another. B, all of these codes, these QR codes, everybody in the world, well, not everybody in the world has a computer or a laptop, but almost everybody in the world has a cell phone. These codes are available in English, in Spanish, in French, and in Arabic. And if you, on our website, operationairway.com, all of these codes are available and downloadable, and please use them as you will. And I think that these are very helpful as we're teaching team teaching. Go ahead, Asita.
Yeah, and then this slide talks through kind of the specific, graduation criteria, for each country as Operation Airway kind of goes, and how we use to kind of assess how different groups are coming along. And it's a busy slide, but I think the important thing to note here is that it's not just, now that a surgeon knows how to do the technique, then, they're checked off the list and they can move on. It's actually a rather, all-encompassing kind of, it goes from literally, are you able to kind of do the preoperative workup, decide which type of surgery? Are you able to conduct a preoperative huddle? Are your anesthesiologists able to communicate appropriately with the surgeon and the nursing staff immediately prior to the OR? Obviously, the surgical technique is important to learn, but then afterwards, it's also intensivists, pediatric intensivists assessing the local pediatric intensive care unit as to how they're taking care of the patients postoperatively to make sure that that postoperative care is also safe and effective. Similarly, our nursing staff, our ICU nurses assess their ICU nurses, and again, kind of in the postoperative care as well. And so it is what we call a discipline to discipline, kind of assessment. And so surgeons make sure surgeons are okay, anesthesiologists make sure anesthesiologists are okay, et cetera, et cetera. So that's what this slide is trying to show.
And I would say here, just to say, in the COVID era, I was not able to graduate Asita other than by Zoom graduation, which was very sad. And I similarly, I was looking forward to our trip this fall with Marcos to formally graduate his program because of the unbelievable work they have done to create team units. My hope is there will be a vaccine and I will be able to formally graduate Dr. Bonilla and his program in the spring. But then we look forward to working together to teaching in Colombia and Peru and elsewhere together as teams as we help other teams graduate these programs together. Asita, want to continue?
Yeah, and I think one of the other things that's important is not going in with too narrow of a focus. I think that one of the things that we have noticed when we started looking at the data was that, this is specific to El Salvador, but all the pediatric ICU mortality was 26%, 26.7%. And we thought that was high, and we started to look into reasons why that possibly could be. And we started looking at how the endotracheal tubes are being placed, how they're being sized. Are they using cuffed endotracheal tubes appropriately? These sorts of things. And we noticed that there certainly were areas of education that we could improve upon. And so we designed a multidisciplinary kind of low-cost intervention in which we taught, the local ICU, the nurses, the intensivists, a specific taping protocol that uses a tape designed for kind of high humidity environments, which is very low cost, about $1 a patient. And then cuffed endotracheal, we also supplied cuffed endotracheal tubes and taught a course up to how to size these cuffed endotracheal, how to use them, and how to care for them. And we measured data on almost 1,000 patients, 900 patients before the intervention, and then after the intervention as well, and found that after our educational module, the use of cuffed endotracheal tubes increased from 12 to 36%, and that cuffed endotracheal tube use was associated with a reduction in accidental extubation rates. Accidental extubation itself went from almost 30%, got almost cut in half, to about 17%. And you can see it dropped by 48.7%. And subsequently, mortality that we observed from pre-intervention dropped over 4%, from 26.7% to 22.4%, which is remarkable, especially considering that the number needed to treat, the number of children needed to prevent a mortality using this sort of intervention is only 23.3 patients to prevent one child's death, which is even more remarkable if you consider that the intervention itself is costs about $1.32 per patient to provide, in terms of the disposable cost, the cost of a cuff tube and the cost of the tape that's necessary. And so the incremental kind of cost reduction per mortality is about $30. And so this is in here to just basically show that with with coming in and learning from looking at the data, learning from the local teams about where they feel that their education is lacking, and then designing a strategy to address that can have significant measurable outcomes. And I think that's something that a lot of missions that have in the past failed to kind of create this sort of with scientific rigor show low cost public health interventions that can have significant impact.
I think that's just it's such a wonderful demonstration of what can be done and can be done in a situation with whatever resources you have, but with leadership and with skill and with foresight. And maybe in terms of where one goes together and where we travel now, Marcos, if I am a surgeon anywhere in the world and I listen to this lecture and I say, I'm worried about my children with tracheostomy tubes, but because they might die, and I want to care for them and build a team, but it seems too complicated and it's going to cost too much and I won't be able to do it. How would you answer that question to them?
I think that is 100% possible, because you only need to make some changes in your area to organize this kind of program. I said that because Dominican Republic is a poor island, and we can do a strong and safe airway program in Dominican Republic with a high success and give my patients some hope and results. I think that is 100% possible. You need leadership, you need make a good team, but I think that is 100% possible.
Evelyn, maybe we could have Jose address the question. If we were to start a program similarly, if he was to teach the doctors in Guatemala or neighboring countries how to start such an airway program, what advice would he give them? You're on mute.
Doctor Bonilla, pregunta el doctor Harney que si fuera usted a construir este programa desde el comienzo en países vecinos como Guatemala o Honduras, ¿cuáles fueran los pasos que tomara y cómo usted creara este equipo, que fuera su opinión de cómo pudiera recrear este programa?
Así como se ha creado en mi país, en El Salvador, comenzando por enseñarle a los intensivistas, a las enfermeras de cuidados intensivos, a los pediatras, los anestesiólogos, cómo es el real y verdadero manejo de la vía aérea.
So for Dr. Bonilla, he thinks he would start the program like Operation Airway started in El Salvador. He said that he would first try to get together with the teams, including ICU, including nursing, including anesthesia, pediatricians, and to teach them how do you manage airways? What is the way of actually caring for patients with difficult airways?
Well, Evelyn, if I were to ask you, you who have been all over the world and back, culturally, when you start and you speak to a new country and a new hospital and a new team, what are the pushbacks that you feel in terms of starting, and what would you say a recommendation would be to start and do this well?
Well, I think one of the main lessons that I've learned throughout the years is to understand that we are guests in these countries and in these hospitals, and we are here to serve their needs. We can't come with a cookie cutter program and say, this is what we're gonna do, this is how we're gonna implement it. We have to acknowledge that we're guests and that these are very skillful doctors, nurses, pediatricians, healthcare providers that are looking for knowledge because they're already treating their own kids. So I think for me, one of the biggest lessons has been to understand the cultural differences, to acknowledge that every country will have different needs. Every country will want a different program, and we want to create those bonds and relationships with each country that would surpass what Operation Airway wants to simply do, but we want to become friends. We want to, I think, and also an important part is to understand those cultural differences, even to treat patients. I think it's very different, the language that they speak, even if they all speak Spanish, they have different wordings. And I think it's been wonderful to see if we create those alliances with the local doctors and understand their needs, we understand the patient needs as well. We can't understand patients in different countries and their own needs if we come with a different plan from, for instance, the US. I think that has been very helpful to address the social difference and the cultural differences for each country.
I have to say for myself, I feel these types of cross-national collaborations have made me feel very blessed in my life to have friendships like with Evelyn and Asita and Jose Bonilla and Marcos Mirambeau, and not just to go and teach, but to learn from them, to see how Jose interacts with his patients in his language and their language, and how his informed consent may be different than my informed consent, because he doesn't have EPIC, thank God, and doesn't have the types of electronic technology that we are suffering through. But what's important is that he connects, and his relationship and his desire to learn. And to sit there with Dr. Mirambeau, watching him speak to his patients and seeing him react to them and see them through the surgery and care for them the next day and teach his intensivists, I think it's what ties medicine all over the world, is that what we want to do is work with our children, and we want to save them and keep them safe. And remember that airway surgery is about getting these children, yes, so that they can have their tracheostomy tubes, but later in life so that they can breathe on their own, speak on their own, eat on their own, go to school, become members of our community and work with us. And to do that, we go slow and steady and safe. And we do that as a small community of people working together. So for those of you who are listening to this, again, on our website, operationairway.com is our ways of reaching us. But for those of you who are more local to Dr. Mirambeau or Dr. Bonilla, reach out to them, because they have learned and they have taught us, and they are just a member of our growing team. And we hope this has been helpful to each of you who are thinking of either developing your own missions, whether those would be in airway work or ear work or sinus work or what have you. But I encourage you that this is an immense project in terms of that the world is large, and find friends across the world to teach, to learn from, and to work with together. So thank you for spending your time with us, and we hope this has been educational. Thank you.